Very good afternoon, friends. Welcome to the webinar series on COVID by Clinical Infectious Disease Society. Since we have completed already 4 lectures, today's will be the 5th lecture, and the overall reception for the initiative has been very good and has been very encouraging. And COVID is special. Infection control in COVID is even more special. And to talk about those special situations with infection control, we have an eminent speaker, Dr. Subramaniam Swaminathan. And the speaker will be introduced by Dr. Ram Gopal Krishnan, who had already delivered the 2nd lecture, who is a senior consultant in infectious diseases at Apollo Hospitals, Chennai. Before I give the mic to Dr. Ram Gopal Krishnan, a few housekeeping announcements as usual. And please key in questions that are relevant pertaining to this talk alone. The talk is on infection control in special situations. Let it be the operation theater, labor ward, dialysis, transplants, and oncology. So I request the delegates to key in questions relevant to this topic. And the first 1,000 attendees will have the access through the Zoom app. People who come in late can watch it live through the YouTube. All we have to do is type in SIDS webinars, and if you're going to type in SIDS webinars, you can do that. You can watch it live in the YouTube, and all these lectures, whatever we have done, are all put up in our website, sidsindia.org, which also has a lot of information, which are authentic information, which is relevant to the COVID. We have a separate section on COVID-19. Please log into our website to watch the lectures, plus to key in those relevant information which is required in the clinical management of these patients. And I would just hand over the mic to Dr. Ram Gopal Krishnan to introduce today's speaker, Dr. Subramaniam Swaminathan.
Thank you, Ravi. Thank you. Thank you for setting this up. It's a pleasure to introduce my good friend, Dr. Subramaniam Swaminathan. Subra is a consultant in infectious disease at Gleneagles Global Hospitals in Chennai and Bangalore. After doing his postgraduate training at Christian Medical College, Vellore, Subra is board certified in the US in internal medicine and infectious disease. He's an extremely well-read physician and a very popular speaker. He has created a name for himself in the field of transplant ID, and he regularly conducts these annual transplant ID conferences. One thing about Subra that rivals his knowledge of ID is his knowledge of the English language. So don't be surprised if you're having to run for a dictionary after this lecture. He's famous for throwing out exotic English words. Over to you, Subra.
Thank you, Dr. RGK. It's actually humorous listening to you as well. And honestly, I must say that the first few lectures so far have been so good. The bar has been set extremely high for me. So I will be striving to see if I can get to that kind of level. So I'm going to be talking about infection control in various settings with regards to COVID. And I already see that people have questions about it. Most of these questions should be answered as we go along. So these are my disclosures. So let me So let me start.
Just tell something because it's wrong with now as well as with
Okay, so let me
sort it out. I'll just check whether it is happening with Subra also. 1 moment.
Okay, so let me start with outpatient activity. For the most part, at least
yes,
at this point of time,
also.
We should be avoiding in-person visits to a great extent. Routine visits for wellness and general checkups should be avoided as far as possible and discontinued or postponed at least. Telemedicine, which the government of India is now promoting, is a very good way of ensuring that people don't have to come to healthcare unnecessarily. And it may be worthwhile screening patients before they come for their appointment. So a day before, somebody can give them a call and check with them if they or whoever's planning to come with them have any fever or respiratory symptoms. It may be worthwhile, and if they do, it may be worthwhile postponing or changing the way you handle that appointment. And you also need to have a standard operating procedure which can reduce the risk in the setting. So what can be done? So obviously you need to have different kind of approaches for different areas. So this is what we have put up in our website as well. So this is kind of modified from what the government of India has put up. So you need to have a triaging area. This is absolutely critical. Any healthcare area needs to have a triaging area so that patients at risk can be identified. And those who have respiratory symptoms immediately have a mask placed. So, all the risk assessment models that you would see, when they talk about it, the most important factor in terms of risk is the patient not wearing a mask. Even more important than the healthcare worker wearing a mask is a respiratory patient wearing a mask. So that's critical. So making sure that they wear a triple layer mask if they have a cough is a good idea. The healthcare worker should also be wearing a triple layer mask because they are screening all these high-risk patients. Then you have a registration counter. You need to have temperature recording. Obviously, a manual thermometer is not a good idea. You need to have a thermal recorder, which is handheld. Then your holding area or waiting area to make sure there is good physical separation and somebody watching over them to make sure that they don't, nobody who's coughing is slipped under the radar. Your own clinic, that where your actual chamber is, you have to look at the way the air flows, make sure that the flow of air is from you to the patient out the window, something like that. But again, you should be wearing a triple layer mask and do not involve yourself in any aerosol generation procedures. Sanitary staff, again, need to be cleaning high-touch areas at least 3 times a day. They should all be wearing a triple layer mask and gloves. And visitors should also be counseled on all these measures. So obviously, N95 mask is a must if you're doing aerosol generating procedures, chiefly things like obtaining a nasopharyngeal swab. Nebulizers are probably a bad idea in this setting, especially if the patient is symptomatic. Metered-dose inhalers are safer. If you want to have a nebulizer, then it has to be, again, a negative pressure room with full protective gear for anybody who's inside, and make sure that the air is not shared with the waiting area or your own chamber. Obviously, you need to fast track those with symptoms. Social distancing and separation, preferably 2 meters, even better, would be nice. Again, decongest your OP so you don't have too many people waiting at the same time. Emphasize hand hygiene and respiratory hygiene. Cough etiquette posters are a good idea. And you need to have a clear protocol in cleaning and disinfection. Even good old hypochlorite is good enough. Air conditioning. Now, this is a question that's been raised to me quite often in the recent past. See, I think it's more about the way the air is handled. Air conditioning per se is not a problem, provided you're not doing aerosol generating procedures. The good news is this is a droplet-based infection in that it is large droplets and it does tend to fall down. But if you're doing aerosol generating procedures, then it's a problem because then now it's an airborne pathogen and it's a different beast altogether. So as long as you're not doing aerosol generating procedures, central AC should not be a big deal. Yes, it is always nice to have good lighting and environmental ventilation. If you have large windows which you can keep open, lovely. But not all of us have that luxury if you're working in a larger center. So an shared AC is fine provided no aerosol generating procedures being done. So please keep an eye on all the aerosol generating procedures. Those are the ones you have to ensure that you have safety mechanisms in place. So any aerosol generating procedures has to be in a separate air handling unit with a negative pressure, ideally with all the PPE required. So long story short, wear a mask as far as possible. Oncology patients, obviously, they are most vulnerable. What was shown in Italy was that 20% of all the COVID deaths in Italy were attributable to oncology patients. And the cause of deaths are multiple in these patients. They may die due to COVID, they may die with COVID, or it can be an impact of COVID in that there is denial of services because of the overwhelming mass of humanity who come in during these periods, because of which oncology patients may not get the required services. This is not just true for oncology, but for any critical care sector. So what they found was from the Chinese registry and the Italian registry, it appeared to be more common in patients with lung cancer, patients who are older, patients who are smokers, and those who had recent chemo or surgery. Keep an eye on the last risk factor because that becomes a little important. So what they showed was, if you had no cancer, as compared to people who had no cancer, even cancer survivors had a higher risk of being in the intensive care unit and more likely to die. And those who had active cancer were even worse off. So obviously, even cancer survivors do poorly, but patients with active cancer do really badly. So it's important to make sure that this group of patients is well taken care of. So the Chinese experience, what they had published to us, they said they implemented universal screening at the time of entry into the hospital. They had multiple temperature checks in that at multiple points, they had the temperature rechecked even for a single outpatient visit. They also had travel and exposure history being evaluated. They promoted online consultations to reduce contact. If there was fever and cough, they were evaluated with a PCR and a CT. This was their protocol. I'm not suggesting that we do a PCR and CT. You have to take appropriate judgment calls, but it may mean you may need to do that. And remember, a person with lung cancer has become so much more difficult to read a CT scan. And switch to oral agents if there are oral options for the same thing. And if you're doing regular monthly chemo or something like that, they have to be evaluated to see if you can increase the infusion duration, so that instead of coming in every 4 weeks, maybe if you can come every 6 weeks without significantly compromising the efficacy of the treatment regimen. Those kind of interventions could reduce the risk to the patient. So in general, there is a good practice statement. One, classify them as, if you need to do surgeries, let's say, classify them as category A, urgent, category B, within the next 4 to 6 weeks, and category C, routine. For example, an obstructed system would be a category A. Category B would be where you don't want to wait too long because you run the risk of the disease moving forward. And category C is routine surgery. So category C is a very easy answer. Do not do it now. If you can wait on it, let it take it down the road, maybe 3 to 6 months. Category A, obviously, you don't have a choice. It has to be done now. Category B is what you need to be sensible and try and see how you can time it as far as possible. So protocols, if deferral is best. Interrupt chemo if it's feasible when the transmission is high. Like if the transmission in that area is quite low, then chemo may not be a bad idea. On the other hand, if the transmission in that community is very high, then chemo may be very highly risky. For radiation therapy, there is a concept of hypofractionated schedules. Again, whether it makes sense for that patient or not, you need to have a discussion with the radiation oncologist. And of course, very importantly, do not withhold critical anti-cancer immunosuppressive therapy, because a significant number of deaths happen because of this issue as well. So there are specific resources on all of this. So the breast surgeons have put up their own guidelines in one area, and oncologists have put on their own guidelines in another area. Hematology oncology has guidelines, surgical oncology has guidelines, and the ASCO has also put out some good guidelines. It is worthwhile going through all of these for specific issues. And again, remember that this is meant for an international audience, not necessarily our group, but the basic principles are still convertible. So again, it's not a one size fits all. So you have to look at the principles and see how it applies to your population. What about transplant? As far as the stem cell transplant is concerned, I thought the NICE guidelines were pretty sensible. Do autologous transplant only if it's an emergent setting, because most of the time autologous transplant is something which can be deferred for some time. Non-urgent allogeneic, for us, that is for non-malignant purposes like thalassemia, things like that, has to be deferred. And even for those with urgent, be careful if they've had any contact with a COVID positive person for at least 3 weeks, because that's kind of going over the incubation period. And when you have the donor as well, you know, it's a unrelated, when you have a separate donor for allogeneic, you need to screen the donor by history and make sure that they were isolated for at least 4 weeks. If you don't have clear isolation history for the donor for at least 2 to 4 weeks, then it's a little bit of a risk. There's really no foolproof way of assessing this. Some people have done RNA PCRs on the blood or the stem cells that come in to see if there is a transmissible risk, but unfortunately, there's no standard guideline over here. And of course, always strict isolation precautions, because the other big issue is about nosocomial transmission of COVID. As far as solid organ transplantations are concerned, it's best to defer transplants as far as possible. Kidney transplants are never emergent because you always have dialysis. So that's not an issue. The issue is going to be with other transplants like liver, heart, and possibly lung. And lung especially represents a very high risk setting, so you have to be very careful. So if the transmission is very widespread, even the disease program may be quite risky. The problem is that movement of risk teams from one area or one hospital to another may also increase the risk of transmission. Very often what happens is that the recipient team will go to the donor hospital and harvest the organs. This comes at a risk of, if the donor hospital does not have great infection control mechanisms in place, you run the risk of the team also getting infected and then propagating a transmission chain in your own hospital. So that's a concern as well. And also look at the risk related to the donor and infection control practices at the donor side, because very often, even if the patient did not come with coronavirus, the patient may have acquired COVID if the infection control practices at the donor hospital were not up to scratch. So what would we suggest? Transplant should only be done in centers which have dedicated facilities to ensure the safety. You need to have earmarked pre, peri, and post-transplant areas, including operation theaters, which are not general purpose and used for other patients. The staff involved in these kind of transplant patients cannot be multi-purpose and used for care of COVID patients. There has to be sustained availability of personal protective equipment. There has to be clear protocols and patient movement around the hospital to prevent nosocomial acquisition. And of course, there has to be counseling on the risks due to COVID to the recipient and the donor in this setting, especially if you have a live donor. What about emergent living donor? So if you have an emergent surgery, let's say an acute liver failure, and you have an in-house donor, a sibling or something, if it's truly emergent, and if you believe that the other options are associated with an acceptable risk of death, then you'd have to go for it. Of course, in-house donor would be nice. And it would be best if you have the patient and the donor quarantined for a preferable period of at least 14 days and not be around an infected patient. And if you look at the Singapore guidelines, they say a negative PCR in both the donor and recipient would be advisable. So for a cadaveric donor, the recipient criteria should be symptom-free for a period of 14 days, no respiratory symptoms. Obviously, this is not for lung transplant. Quarantine for at least 14 days and a negative PCR before surgery. Donor criteria would be no pulmonary symptoms, should be cared away from patients who have pulmonary symptoms because you don't know which one has COVID. And the donor hospitals have dedicated areas and do not have nosocomial transmission. And the donor should ideally be screened by CT scan and preferably RT-PCR if it is possible. Again, there are some guidelines which are coming out from some authorities which are looking at serology being used. Serology is not an appropriate test for evaluating the donor or the recipient because serology becomes positive only by about day 8 or day 10. And more importantly, if the patient is asymptomatic and the IgG is positive, it usually means the patient has already survived the infection and is possibly immune now, which is actually a good thing, not a bad thing. So serology is not a good test for looking at donor or recipient eligibility in this setting. What happens in patients who do develop COVID after transplant? This was the Italian group. They looked at their liver recipients who were more than 10 years out in northern Italy. They had 111 long-term liver transplant recipients. 3 of them died. And all 3 of them were male. They were older, more than 65 years, hypertensive, overweight, diabetic, and dyslipidemic. You know what? You really didn't need liver transplant to kill them. All these risk factors are by themselves predictive of a really, really horrible outcome. On the other hand, they looked at the 40 recent recipients within the last 2 years who developed COVID. All 3 of them survived because they had no additional risk factors. So obviously, the time from transplant did not seem to make a huge difference. But again, these numbers are really small. This is very early data. This came out less than a week ago. It's just been published online. So this is heartening to say that transplant probably, at least solid organ transplant doesn't really make the situation horrible. But again, the general principles apply. Try to keep the immunosuppression as low as possible. Keep them away from circulation. Keep them home. Do not make them come up and down to the hospital. So obviously, as far as transplant is concerned, on an elective basis, no go. What about pregnant women? So the good news is, like everybody has been saying, there is no increased risk in pregnant women. That's really great. So the usual precautions apply. They do not need any routine testing for coronavirus. There is no virus isolation from amniotic fluid or breast milk, so there is no concern. The WHO has said breastfeeding is not an issue, and in fact, they promote it. The government of India, in its guideline, has said express breast milk should be given to the baby. And as far as possible, they want the mother and the baby to be separated. WHO, on the other hand, says holding your baby is okay. Our government has said if you want to hold your baby, make sure that the mother has a mask and she does hand hygiene. Has there been perinatal transmission? Direct transmission, probably not so. But again, person-to-person transmission of droplets is possible. But the babies really tend to do quite well, even in spite of COVID. Okay. The bigger issue is about pregnant women coming to labor and delivery, because we know labor and delivery is a very difficult situation. And handling a pregnant woman there is pretty tough. So this is a flowchart that I got from University of Nebraska Medical Center, which I think is pretty practical. So when they come into L&D, you assess them. You look at whether they're symptomatic or asymptomatic. If they are asymptomatic, ask them if they have any clear COVID exposure. The good news is most pregnant women tend to stay home. So unless they have a sick contact at home, this is going to be fairly ascertainable. If there is no exposure, you go on as you would normally do with a normal woman coming for pregnancy and delivery. If there is COVID exposure, then think about quarantining them and think about whether you want to do any further testing. Triage them in a negative pressure room. If they are symptomatic, then you have to triage them in a negative pressure room with all the appropriate PPE as for COVID, and think about doing a RT-PCR. If the RT-PCR is positive, you would continue caring for them in this area. And if they are negative, yes, you may consider moving them to triage if there is enough suspicion to say this does not look like COVID. Now, obviously, because it's pregnancy, routine use of a CT scan is probably not a smart idea. But most medical experts are saying that if you need to do a CT, just put a shield and do the CT, because if there is a concern of COVID and if the lungs are involved, then the benefit to the mother is far greater than the risk due to CT scan. And now with the low dose HRCT being fairly available, the risk may be much less. So what should you do as far as PPE is concerned? So if the patient comes in, especially with respiratory symptoms, please give them a surgical mask. What about the providers? All healthcare providers should be wearing a surgical mask in the labor and delivery suite. If the patient has symptoms, that is respiratory symptoms, then the provider should be wearing all kinds of respiratory PPE, which includes a gown, gloves, a surgical mask, and a face shield. If there is aerosol generating procedures, then you need to add an N95 mask to that. So again, remember, aerosol generating procedures would be things which would make it airborne. So this is the LSCS protocol again from AJOG. I'll just try to break it up into pre-op, intra-op, and post-op. Pre-op, again, if there is, this is for proven COVID, or you're strongly sure it's COVID. Again, depending on who the person is, there are different guidelines on what kind of PPE it is to be used, level 1 and level 2. Level 1 would be a gown, glove, surgical mask, and a face shield. Level 2 would be an N95 in addition to that. So this would be for a pre-op, this is for intra-op, and this is for post-op. I'll let you go through these slides at leisure. These slides will be freely available. It should not be an issue. And I've given the reference for all of this as well. Okay, obviously, all of this sounds very easy till you start having to do it yourself, and that's when the fun begins. What about routine surgeries? Now, this is a bigger sticking point because I'm seeing a lot of people saying, let's do an RT-PCR routinely before every surgery. Now, that is hardly a smart move because, like what Dr. Rajiv Soman pointed out yesterday, the pickup of a nasopharyngeal PCR is only about 70%, even in the best of times, for a symptomatic patient. For a person who has a subclinical illness, this pickup may be even lower. So I'm worried that this may lead to a kind of a risk-taking behavior which is not evidence-based, and this doesn't sort out the problem. And waiting for a patient to get an RT-PCR is also an unnecessary burn on the resources that you have in terms of using the RT-PCR kits, and also that you have patients staying for a longer time in a high-risk environment, which is not good. So if it's an emergency surgery where you think there is a concern for COVID, you have to take all kinds of precautions. But it's urgent and you have time to triage it. If you have a low-risk procedure and they have no symptoms, you proceed with standard surgical attire. I'll come to some of these points in a little more detail. If there is surgical delay, then you can think about doing, if there is positive, then you can definitely do an RT-PCR. If it is negative, go with standard surgical risk. If it is higher risk, then obviously think of it as a COVID theater. If if this is a high-risk procedure, then you can definitely think about, I'll come to those. If you can think about doing an RT-PCR, and if it is positive, go for a high-risk situation. And if it is negative and you really think there's no possibility of COVID, then you go for a standard risk procedure. So high-risk procedure, which that table just had, would include anything which involves the upper airway. So nasopharyngeal, oropharyngeal, ENT. Please also include transsphenoidal surgeries in this. The surgeries involving the trachea, the lung, the bronchoscopy, or surgery of the bowel where you open the bowel with gross contamination, because we now know that there are GI manifestations of this. So if you're opening the bowel, that's a bit of a risk with gross contamination, not doing some resection with laparoscopy. That would not be a huge risk. So any provider operating on a high-risk patient must have training in donning and doffing appropriately. And a face shield is absolute must for every surgeon anyway. Now, what they recommend is a fitted N95 with a face shield to be worn by all anesthesia. And so what they should do is, ideally, the recommendation would be right after the PSU, have a negative pressure room where the anesthetist can intubate the patient. And during the time of intubation, everybody leaves the room. Only the anesthetist in the room. The anesthetist is wearing an N95 and a face shield, and if possible, putting a hood on the patient to minimize the splatter of the secretions. And after intubating, within 15 minutes, with good air circulation, which happens in most OTs, you will be able to clear the virus from that area, and then people can come in. So making everybody wear an N95 and keeping everybody around is not a good idea. It's important for the person who's intubating to be alone with the patient do it quickly, do it with the minimum amount of fuss, do it with as many precautions, and wait for about 15 minutes, and then move the patient to the actual theater. Then other people can come in. All other people can just wear a regular mask if this is a low risk situation. Obviously, those who are cleaning the operating room should also wear droplet precautions. Of course, a CAPR is nice, but I don't think we're going to get it. If you have a CAPR, all the best. So, couple of points. Place alcohol-based hand rubs on the pole to the left so that the anesthetist remembers that he has to wash his hands and wears a double glove. It will be good to have a wire basket with a zip closure bag on the right pole so that all the contaminated instruments like your laryngoscope and all that can go into that, and that can be zipped closed so that those don't contaminate the rest of the area. And make sure there's a clean and dirty area, and make sure everything is wiped down with a disinfectant immediately after the procedure. And it has to be top down so that you have good control of the bioburden. Decolonized patients that you can think of, this has been suggested because there is some data that gargling with povidone may be a good idea. So maybe some chlorhexidine wipes, povidone gargles, or whatever it is could be options. Using closed lumen IV systems so that you don't have blood coming through, and also data feedback. And obviously, if you have long surgeries, it's better to have long shifts rather than short shifts. You don't want too much churning of manpower. So using long shifts is a good idea, and having less people doing it. Like for example, if there are 8 cases to be done, instead of having 8 first start cases and having 8 sets of people going in, it's better to have 2 teams complete all 8 cases, which are short cases, so that each team has 4 cases and they finish by the end of the day, so that you are not burning through all your manpower at one go on a daily basis. And of course, do 1 case in each operating room, and then do terminal cleaning after each use. And it doesn't take a lot of time because you switch the air handling on at full blast. Within half an hour, you've actually reduced the bioburden to the level that people can walk in with a simple face mask and clean up the place. Of course, do not move them into large pooled areas, because if you have one person coughing over there with an unknown COVID situation, they end up contaminating the whole place. So obviously, it's better to move them to single rooms after that. Obviously, ICUs, again, remember, if you're moving them to post-theater ICUs, keep in mind that if you're keeping them on a ventilator, it may not be too difficult, but if you're extubating them, please be careful about that as well. Logistics, theaters remain positive pressure. A lot of people are talking about making the theater negative pressure, but that increases the risk of nosocomial infection to the patient, and that's probably not a smart idea. Intubation and extubation, ideally in a negative flow room with all the precautions, and wait for 15 minutes before entry, limit manpower, and leave the door closed for 30 minutes after surgery, and then commence routine cleaning. Obviously, the SAGES guidelines is what has got everybody at Twitter, and it says all of that is good. Postpone elective stuff, do safety measures. And here's the point. The point is they have talked about carbon dioxide filter. Now, this is, unfortunately, I don't think anybody's read the references for that. The references are based on hepatitis B and HIV, which are intensely viremic. As was just mentioned by Dr. Raju Soman yesterday, this is not an intensely viremic situation. There is very low levels of viremia, and in asymptomatic people, you probably don't even have much viremia. So to expect a viral contamination of the theater of the carbon dioxide doesn't make sense. So again, I think this is more theoretical concern, and there is absolutely no data to back it up. And I'll tell you why this approach is wrong when I come to the blood bank section. So again, endoscopy, be very careful. Now this is also high risk. You need to wear full PPE. Lower segment endoscopy, lower GI scopy is probably less risky. Upper GI scopy needs a lot more consideration. And do not avoid procedures which involve carbon dioxide insufflation. And procedures should be considered high risk. And these require the same kind of precautions that the theater requires. So this is a kind of a flow chart on what kind of masks and whatever you need to PPEs that you need to wear. You can go through it at leisure. So basically, this is why the guidelines are where they are, and why some of them, in my opinion, don't really make a lot of sense. Blood bank. So obviously, you need to triage everybody, social distancing, hand hygiene, cough etiquette, all this stuff is there. This is the National Blood Transfusion Committee or whatever it is, the Indian government. So the donor evaluation, again, you do the usual stuff, but you also ask for travel, contact, personal illness history. And if you're looking for convalescence, I'll come to that in a little later. So obviously, if there's a big cluster, you avoid patients who come from that cluster. The WHO also says it may be worthwhile thinking about quarantining blood for 28 days. So if somebody's donated blood today, if you can quarantine the blood component for 28 days, give the patient a call and ask him, dude, are you okay? And if he says yes, then maybe you can release it. Obviously, this will not apply to platelets. Obviously, you need to do donor education. As of right now, there is no role for routine testing. There has been no cases of blood-borne transmission so far. The good news is, as far as plasma and its derivatives are concerned, all the steps involved in it have multiple things which kill viruses, so you don't have to do anything extra about that. What about convalescent plasma? WHO clearly says they don't have guidelines as yet. They are asking us to extrapolate from general guidelines and Ebola guidelines, and that would be, look at those who have recovered from COVID-19. You have to take them only after 28 days after discharge, and they should be asymptomatic and preferably PCR negative, otherwise usual safety measures. What is the FDA say? Usual donor requirements. They should either have had a positive PCR or illness, or they accept a positive serological test after an illness consistent with a COVID-like situation. And there should be complete resolution 28 days earlier, or at least 14 days earlier with a negative nasopharyngeal or a blood PCR for COVID. And you want to have a neutralizing antibody titer of at least 1 in 160. And the FDA themselves realize that they don't have all of this. So they say, store the plasma and give it as you need it, but later on we'll go ahead and test and see if it was good enough. So obviously all of this is in context. You need to infer from context and see how the risk is. Dialysis. Few more segments to quickly cover. Obviously, call the patients and talk to them, try some outside, mask, usual risk guidelines for all of this. It's also from the Ministry of Health and Family Welfare. And distancing, avoiding attendance, and keep 2 meters away, clean and disinfect. All of this is just routine stuff. Now, obviously, if you are caring for a person with suspected or proven COVID, then the PPE should include shoe cover, gown, surgical mask, goggles or face shield, and gloves and a mask. N95 is preferred, but they've clearly said, but if there is a shortage, even a triple layer mask is acceptable. Okay, so obviously we don't know the answers to all of this stuff. So very simply put, if you are handling a patient who is coming for dialysis, you need to plan for it well in advance. You have a patient who comes in and they have no risk factor and they don't have any symptoms. Whether to put them on a mask on a routine basis is debatable, because they're going to be there for a significant period of time. You can think about giving them a mask, but make sure that the beds are at least 2 meters from each other. Good spacing is a good way of ensuring that you reduce the burden by droplet precautions. Second, make sure that all your healthcare workers are wearing at least the surgical mask and perform good hand hygiene. And those with respiratory symptoms should be kept in separate areas where you can have better coverage, and these staff cannot be shared with the regular area. And it is important to ensure that if you are going to the ICU for CRRT and things like that, then those ICU precautions have to be put in place. These may not be adequate. So obviously we don't have all the answers to everything that we need, but we'll try and keep looking. I think that's the end of my slide set. Wow, I managed to make it in time. Hang on. Yes. Yeah.
Okay. Okay. Thank you, Subra. You can hear me, I hope.
Yeah. Awesome.
Right. So as usual, there will be the standard barrage of questions on, and we try to just restrict ourselves to infection control, especially in the special situations you discussed. So the first question is, how do you keep non-COVID clinics? I assume the question is infection-free.
So basically, you need to have an SOP. You need to have the general principles apply. You need to have a system of triaging. You need to have a system by which you can identify people who are at risk or people who can have a respiratory illness and try and keep them separate. In general, decongest and reduce footfall. So at this point, at least, those are the principles, and also making sure that adequate PPE is being used by the person who needs it the most, and reducing aerosol generating procedures. So if you look at the list of things that we went up, it's also there in our website. I would advise that you have a look at that guideline, and it is practicable to be able to do that.
Okay. Is labor an aerosol generating procedure?
Okay, labor is not an aerosol generating procedure, because remember, you're not coughing. If a person is coughing and if the person is getting a nebulizer, that's an aerosol generating procedure. But labor by itself is not a aerosol generating procedure. You can get splashes and things like that. But the good news is amniotic fluid has no virus, and the blood also, the risk is very low because the amount of viremia is actually quite low. So no, it's not a high risk situation.
Okay, a question from a gynecologist. Is an emergency gynae-related laparotomy comes up, can we go ahead with a laparoscopic procedure? Emergency laparoscopic gynae surgery, is that okay?
Yes, it would be okay. Again, do the same risk stratification that I put up in the chart. If the patient has respiratory symptoms or is at risk for COVID, then obviously you upscale your PPE. If you don't, your regular PPE should be adequate. The risk is primarily for the anesthetist, and that person should take additional precautions, as is mentioned.
Okay, one question. How far does the minute aerosol that you generate during normal breathing travel?
See, again, the point is that unless you have virus, that aerosol is of no consequence. So unless a patient is infected, why are we worried about aerosol? The second thing is, again, it is that's where coughing and things like that come in. See, very often the surgeon is quite a distance away from the patient. So really no risk. It's the anesthetist who's right next to the patient, and that's the person who's at high risk. And lastly, in theater, your air exchanges are far more rapid than in any other place in the hospital. So actually speaking, that protects you to a good deal.
Okay. Is it absolutely essential to have a negative pressure room for collection of nasopharyngeal swabs?
It depends on how much you value your life. The answer is yes.
When would it be ideal to resume elective surgeries?
My crystal ball is broken. I would suspect, say, 3 to 6 months. I don't know.
Okay. Is it required to quarantine the healthcare worker who's collecting nasopharyngeal swab with PPE, including an N95 respirator?
No. Again, see, there are protocols which have been defined for high-risk exposure, medium risk, and low-risk exposure. So unless you have a high-risk exposure, you really don't need to quarantine everybody. I promise you, there will come a time, even high-risk exposure, people will be said, you please go to work because we need people to work. And that's what is happening in the Western world. I'm not saying we are there yet, but let's not be overzealous about quarantining people for low-risk exposures.
Any difference in risk between LDLT and DDLT in terms of COVID exposure?
Absolutely.
Donor, deceased donor.
Absolutely. See, when you say disease donor, you need to know why the patient died. Second, you need to know how the patient was cared for. Because one, it's a question of whether the person came in with COVID to the donor hospital. And two, did the donor acquire COVID during the stay in the donor hospital? Both of these are independently important. The second thing is, was the recipient in the incubation period? The same rules apply for the living donor also. Please go through the slides. Actually, I've answered that. It's a very tricky answer. So unless the person's transplant is something that cannot be deferred, at this point, routine transplants is probably a bad idea.
You need to put a COVID positive patient who's in labor in a negative pressure room.
Absolutely. Absolutely, yes.
Okay. Many OB-GYNs insist on personal protective equipment before delivery / LSCS. In the absence of rapid point of care testing, what should we tell them?
I think this is where the government needs to step up and put up a guideline. The problem is that this is not evidence-based. There is no guideline which says RT-PCR should be done. And like I said, even if you do an RT-PCR, its pickup is not great. And what you don't know will hurt you. So there is, and doing rapid tests, those don't make any sense because they will be positive only 10 days after the person develops infection. And to me, if the person is asymptomatic and the rapid test is positive, that means the patient is not infected, the patient is immune. So that is in fact the safest patient that I could operate on. So it's basically a lack of understanding of the risk evaluation, and those people need to be educated on all of these things.
A similar question, can serology before surgery aid in PPE allocation in areas of limited availability?
Unfortunately, no. Remember, when you say serological tests, I'm talking about antibody-based tests. As of right now, antigen-based tests are not performing well enough. That may be a different answer. But for antibody-based tests, given that it takes at least 7 to 10 days, 8 to 10 days for you to have a decent answer, it is not going to help us decide who needs what.
Should a dialysis room be negative or positive pressure?
It needs to be normal pressure for regular patients. If it's a COVID positive patient, then you have to decide. Again, droplet precautions are probably enough for the majority of them. But on the other hand, you have a patient who's on a ventilator, or if a patient requires nebulization or something like that during the dialysis, then yes, you are stuck having to require a negative pressure.
Can we take a suspected antenatal COVID case for LSCS?
Yes. Treat them as a positive COVID if you are suspecting COVID. That doesn't mean treat everybody as COVID. If there is a suspected case, treat it as a proven COVID and take all measures, which basically means your PPE requirement will be at the highest level.
Why is nebulization of, say, salbutamol considered high risk?
Very good. When the patient coughs, the patient is coughing a lot of virus into it. And this goes directly back into the nebulizer machine and the nebulizer fluid. And now you're actually nebulizing the fluid, which makes it airborne and therefore creates a risk for everybody around it.
Can we undertake routine vaccinations now?
Yes, you can. No harm at all. But that doesn't mean you start gathering people in large crowds because you don't know who's come for vaccination, who's come for a health requirement. So if you have a separate vaccination test and, like I said, phone triage and make sure that they have no symptoms and all that, yes, you can do it quickly. But if it is something that can be deferred, it's probably a good idea to defer. Not that vaccination is a bad idea.
Any protocol to follow up post-op symptoms, post-op patients after the surgery for development of COVID symptoms?
Unfortunately, no. It still falls under the same paradigm. If they have a fever with respiratory illness, you have to consider the possibility that this could be COVID. And at this point, at least, since the outbreaks seem to be fairly localized, exposure history, travel history, and things like that could be of use. But once it becomes generalized, all these things are going to be useless. So yes, you have to go by clinical decision making.
A question from a gynecologist: suspected COVID. Would you advise LSCS or C-section?
Okay. So is C-section better than vaginal delivery, or is it the other way around? See, normally speaking, some references that I looked at about, I talked about doing an LSCS if there is a concern that the first stage is going on for too long, because you don't want the pregnant women with possible COVID to be staying in the labor room where there are a lot of other pregnant women. That is fine. But also remember that we have to restrict the amount of time that the patient stays in the hospital per se. So in fact, in the Western world, they are discharging even LSCS patients 48 hours after surgery because they say you better off taking care at home. So my point is this: you have to look at what will reduce the stay of the patient in the hospital. If you think that the patient is unlikely to progress and the patient is going to be stuck in first stage for a very long time, you could make a case for LSCS. But the most guidelines say that the indication for LSCS should be obstetric indications, not COVID.
This is from somebody who has done duty in COVID ward for 10 days. After how many days can I resume my normal OPD if my second swab after 7 days of duty comes negative?
Why do you need a swab? See, if we start swabbing everybody who's been posted in the COVID ward, I'll tell you, we'll run out of the PCR kits in no time. So no, I would go by clinical symptoms. And if you're symptom free for 14 days, you can probably restart your OP. That's fine. But I would take a break for 2 weeks.
How infective is amniotic fluid?
No risk.
Okay. How to test and handle neonates born to COVID positive mothers? Again, could you clarify the issue of separation of mother and baby, etc.?
Absolutely. So there is no vertical transmission of COVID because remember, it's not a viremic illness. So babies don't get it at birth and the amniotic fluid is also not positive. So if you look at the government's guidelines, they say they are in favor of separating the mother and the baby. Breast milk again doesn't have the virus. So the recommendation is to give express breast milk, which is to be fed to the baby by a family member or somebody else, and physically separate them till the mother gets better. That's what the government of India has recommended.
In a non-COVID ICU, can you perform open suction for an intubated patient?
Okay, so you have to risk assess and make sure that this patient is unlikely to have COVID. But even otherwise, from an infection control point of view, inline suctioning is always a better option than open suctioning. So here's an option for you to talk to your management and say, guys, we need to move to inline suctioning and not have open suctioning.
Okay, do you suggest fogging after surgery for operation theaters?
That's not going to help. You need to have good wipe down. See, I'm worried that people use these kind of shortcut techniques to kind of cement over, irregularities or deficiencies, and that to me is concerning. I think a good top-down cleaning of, especially flat areas, is absolutely critical because the virus tends to settle on it. Yes, your fogging will kill it, but that doesn't take care of everything that you need to do. There is no real good alternative to good deep cleaning.
Okay, regarding part preparation of a patient before surgery, any specific recommendations, disinfection?
No, nothing specific, as usual.
Okay, what precautions to be taken while collecting and sending a biopsy sample to the lab?
It depends on what you're biopsying. If it's an endoscopic biopsy, obviously the endoscopy rules apply. But if it's a regular biopsy, again, let's say, I don't know, skin biopsy is something, really no risk. Remember that, as long as you clean the patient and you wear a mask and the patient is asymptomatic, you're fine. So again, regular PPE is more than enough. A good mask is more than enough. It all depends on what you're biopsying. If somebody is going to biopsy something from inside the mouth, yeah, obviously that's a higher risk situation. But otherwise, really no.
Okay, if the central AC is put off, can patients be given a table fan, or do we allow them to sweat to death? That's the last part is mine.
No, please don't switch off the AC. It's getting more and more oppressive. I mean, in Chennai, Dr. Ajike can also tell you that it's getting insanely hot and humid. You want to shoot yourself in the head. Honestly, I don't think switching off the AC makes much of a difference. Yes, if you can get natural ventilation and good breeze from outside, you know what, that's lovely. Good sunlight, good breeze, awesome. But not all of us have the luxury of that. So please do not switch off the AC. Make sure that you're not doing any aerosol generating procedures, and make sure that patients with a cough are wearing a mask. That's all you need to do.
Okay, Dr. Camilla Rodriguez from Mumbai says that the Supreme Court has recommended N95 in emergency triage, screening area, temperature recording. Do you have any comments on this from a technical or a science standpoint?
I'm going to start writing some judgments for the Supreme Court starting tomorrow.
Okay. Practice recommendations for immunosuppressed doctors.
Okay, so if you are an at-risk doctor, this is a time for you to take a step back and start wondering why, whether you should be involved in this. I had a discussion with the Urological Society of India. One of this happens to be a transplant recipient himself. So the questions came up about what he should do. Now, these are tricky areas. See, because a lot of people have the misguided opinion that some things may be protective and some things may not. I've just talked to some of my colleagues in the US, and they are telling me they have lupus patients who are on hydroxychloroquine for a long time in the ICU in very sick situations. So it's not as simple as that. So it all depends on your other risk factors and the amount of immunosuppression. So in the liver transplant, if they happen to be young and otherwise healthy, the immunosuppression didn't make much of a difference. But on the other hand, if they had significant immunosuppression and they had other risk factors, it is a problem. So yes, immunosuppression is an independent risk factor, but it is multiplied by your other risk factors which may be present. So keep an eye on that. And if you are an older person with immunosuppression, then it's probably not a smart idea to be involving yourself in any COVID-related care at this point of time.
Okay, what are the chances of contracting COVID if you come in contact just with the clothes of a COVID positive patient, assuming you didn't have proper PPE?
Right. So that's why the recommendation is the clothes should be put in a hamper, into a clothes hamper, and the person picking it up should not do this. Tossing it up in the air and doing things like that is a great way of nebulizing it. The idea is that the clothes, when they are taken off, they should be rolled and dropped into a bag. And this should be soaked in hypo and then sent to laundry for further processing. If you're doing it that way, there's really no risk. And yes, wearing a simple mask is a good idea.
Okay, so do we need to do special counseling to patients and legal implications counseling that they may pick up COVID during hospital care?
This has been floating around, and it's a general good practice to tell patients that, these are things that are out of our hands. We do have SOPs in place. See, remember, when a court looks at it, they look at whether you have proper SOPs. As long as you have proper SOPs and you follow them, if mistakes happen, they know it's beyond you. So keep that in mind. So make sure your SOPs are there. Make sure you're doing your due diligence, and also counsel your patient and you tell them, see, listen, I can't control everything. My problem is if another patient lies to me, what can I do about it? So get that disclaimer done. There's nothing wrong with it.
Okay, a family physician wants to restart a clinic setup. Should it be ventilated or air conditioned? Should there be a triage area? Can you ask patients to sit on the roadside?
In the sun and whatnot, is it? Okay. From an infection control perspective, that may not be a bad idea, but from a patient point of view, it must be pure health. So the short answer is make sure that you have a systems in place. Yes, you need a triaging system. Yes, you need to identify patient service. Yes, you need to ideally do the phone triage and then an in-person triage, and then make sure there is physical separation, hand hygiene, cough etiquette, and all that. If you can get all of that going, it is possible you may be able to restart.
Can you use hypochlorite spray in a family physician setup to clean it up?
Like a bath? No, it's a bad idea. There are good reasons why you should not be doing things like that. All these hypochlorite tunnels are at best unisolated. Please understand, it's a respiratory illness. Putting hypochlorite on the person doesn't really do much. you know, we are talking about using a mask. How will, unless you want to make them drink a lot of hypochlorite, which will definitely kill them. So no, please don't do things like this.
GA or spinal for LSCS?
Right. That's a good question. The answer is it's not clear. So spinal and regional anesthesia is considered safer. That is a very important point. But here's the point. That also means that if you're managing them under spinal, you have to be prepared for, the anesthetist at least has to be prepared for the feasibility that sometimes the patient starts coughing when they are coming out of spinal and things like that. So you should be able to manage it and probably keep them keep a hood near you, and so that if they start coughing, you put the hood and maybe give them a mask so that they don't contaminate the area as much as they do. But in general, regional and spinal anesthesia is preferable over GA.
This incentive spirometer that is given to cardiac patients, is that a good idea, safe?
If they're going to start coughing, again, bad idea. If they're going to start choking on it, bad idea. So again, if you're going to do an incentive spirometry, let them do it when nobody else is in the room. Make sure the room is well ventilated and well aerated. That should be reasonable.
Okay, should PPE kits be used by healthcare workers like lab personnel who are not directly exposed to patients?
There are guidelines on this. Remember that for patients who are handling the nasopharyngeal swabs and those kind of samples, yes, a PPE plus an N95 is recommended. But for all other lab workers, you don't need a full kit PPE. Just a plain mask is more than adequate. You don't need anything more than that.
This question is about unrecognized exposure. If our OP patient becomes positive later, should the hospital be closed? And what about the staff?
I am not in favor of closure of hospitals. Let me explain why. See, if you suddenly close the hospital and start chasing the patients away, all those patients who may be infected in the quarantine and in the incubation period, now will go to other hospitals and set up chains of infection over there as well. So I think this random closure is ill-advised and could cause more harm than good. But having said that, if there is an unrecognized exposure and a person turns out to be positive, you need to go back in time and look, risk assess everybody who's come into contact with them and see who has high risk and who has low risk exposure, and accordingly take measures.
Which is better for terminal disinfection of an OT, hypochlorite or bacillocid extra?
Anything will work. See, we use bacillocid, but it doesn't mean that only bacillocid will work. See, the virus as such is not something which is extraordinarily resistant to all these agents. The virus will die. The good news is that's the good. The bad news is it still has to be done properly. If a half-assed job is being done, it doesn't matter what you use, it will not work.
Okay. After operating on a COVID patient and deep cleaning, how much time should the operation theater remain closed?
Okay, so the risk is before, not after. So the recommendation is to run the AC, keep the OT door closed and run the AC for 30 minutes so that you reduce the viral burden in the OT by more than 99.9%. After which the cleaning crew can go in with just a plain mask and disinfect the whole area. After that, you really don't have to wait.
This is an important question. This doctor from the Indian Army is looking at creating a disinfection tunnel for people. Your comments, should they use this, should they not, etc.?
Don't. See, the problem is it takes away the focus from the important things, which is respiratory hygiene, cough etiquette, and hand hygiene. So I think this is a distraction, and people get all uppity about these fancy things, which really don't make a difference in terms of control of the disease. So my sincere request is please don't do it.
Okay. Now, interesting question. If a patient dies of COVID, can they take his organs for donation?
No, no, you can't. No. That's why we said PCR. If somebody is PCR positive, they need to be burnt.
Is it reasonable to restart OP practice at this time?
Well, it depends on where you are. If you are in a hot spot, if you are in one of the red zones, then maybe you should be extremely careful about restarting practice. See, the government is giving guidelines on this. Look at what they're designating your own area as. If you're in one of the clear zones, then you may be easier off. But if you're in one of the hot zones, you have to be extremely careful. But all said and done, you have to follow the good principles that we have put up in our slides.
Okay. Would you advise a doctor who's a diabetic, hypertensive, and has compensated cirrhosis to go to work for 6 hours a day?
I would advise the doctor to take better care of his health. What more can I say?
One question from a microbiology perspective. What are the PPEs that people processing microbiology specimens should wear?
That's good. Okay. So if you are handling in a virology lab, then yes, the risk may be higher. At this point, at least doing viral cultures and things like that outside of a research setup is probably a bad idea. You need to have a higher biosafety level. But for most other work, the good news is you really don't need much because, you know, unless you're aerosolizing it, really nothing much needs to be done. A plain mask is sufficient.
Okay, this question from an ophthalmologist: any specific precautions for an eye OP? And is a face shield mandatory because they often go close to the patient?
Absolutely. See, when you look at it, the people who seem to be more at risk are ophthalmologists because they go very close, dentists, ENT, and neurosurgeons who do transcranial. The cardiologists get into trouble because they don't listen, but that's a whole different problem. But yes, ophthalmologists need to be more careful. Wearing a shield is probably a good idea. And if the person is coughing, for the grace of, for the love of God, please make sure they wear a mask.
Okay. When can an ENT surgery start off as routine? Routine ENT surgery, can they start doing?
Not for the next 3 to 6 months, I'm afraid. The government will tell us, but perception is 3 to 6 months.
Okay. Do you suggest soaking surgical equipment in 1% sodium hypochlorite before sending it to CSSD?
Well, if you're doing enzymatic debridement, you really don't have to do it. You can. Routine CSSD measures will take care of the virus. You don't have to worry too much about it. So if you want to do it, you can do it. Not that it's going to add a heck of a lot more.
One dialysis unit says they had a COVID positive patient 5 days ago. Is it safe to use that unit for future patients using standard precautions?
Absolutely, provided their cleaning and disinfection protocols are up to scratch. See, ideally speaking, if you have 2 meters gap between patients and you have at least 3 times a day wiped down with a disinfectant, and between patients also wipe down everything else. See, you have to budget for more time. So you can't be doing the same number of dialysis every day. So if you have a patient coming in, you do the dialysis, make sure you have somebody cleaning up that area with a disinfectant and make sure that there is no possibility of germ having settled anywhere, and then bring the next patient in. That will probably be the most common sense answer to make sure that you reduce the risk for both your workers and for other patients.
Is an N95 reusable?
Yes, with certain caveats. There are guidelines on this. I like what All India Institute has recommended. Take 4 and once you use one, put it in a paper bag and leave it aside for the next 3 days and then rotate it around.
Your comments on cough suppressants versus expectorants for actively coughing patients.
No, either way, wear a mask, but please, for the love of God, don't make them cough any more than they already are.
Okay, what's the PPE somebody who collects sputum should wear? Sputum for COVID PCR.
Again, sputum cannot be obtained without a good cough. Therefore, I would be very careful about it. Again, why are we getting sputum? The recommendation is still for an esophageal swab. Sputum, again, yes, the productivity is more, but remember, because the sputum production itself is so poor, very often you're going to get saliva. So please think about that as a problem as well when you're thinking about getting sputum as a sample. Okay, so, but if you want to use it, then because the person is going to be coughing very deeply and all that, I would suggest an N95.
So we're running out of time. So the last couple of questions, can dentists go back to work?
Not yet.
Okay, and one final question. This is a non-COVID hospital. How much time gap between 2 surgeries in the same OT?
Again, see, the same things apply. If you are worried about the possibility that you could have COVID, just blast your air handling unit with about 30 minutes of air and then go in and get somebody to clean it. After that, even if the previous patient had COVID, really no risk. And remember, I honestly believe there's nothing called a non-COVID hospital. It's a question of not yet seen COVID hospital. It's not a non-COVID hospital. You were all going to see it. The question is when.
Okay, thank you very much for that wonderful lecture, Subra, and for answering that volley of questions with a straight bat. Thank you so much. I'll hand this over to Dr. Sintur Nambi.
Subra, very nice talk, and then I love the way that you answered the questions in open and candid manner. Okay, but I believe there are a lot of questions regarding elective surgeries, open or laparoscopic. What would you suggest? Open laparoscopy.
See, again, they're making a distinction which is not a difference at all. In that, the guideline which says that open may be safer, but from a patient point of view, it's not good because it prolonged stay and all that. Again, it's based on the fact that it will be aerosol generating, but the data is from hepatitis B and hepatitis C. So the point is the basic premise itself is flawed. when the blood banks say, people are saying that the blood is safe, WHO is saying it, everybody else is saying it, blood is safe. If the blood is safe and there's no virus, how is the virus going to get to the peritoneal cavity? The answer is it cannot. And therefore, all this concept of the virus nebulizing from the carbon dioxide is BS. So I think there is a basic problem. I don't think surgeons should be writing infection control guidelines. I'm sorry, but that's just my humble opinion.
What do you recommend in your hospital? Elective surgeries? Have you put on a policy, something like that?
You're trying to get me into trouble, aren't you? Let me put it like this. For patients who we don't think have COVID, I think the anesthetist is the person who's highest at risk. I know the surgeons are the ones with all the bravado, but the anesthetists are the ones with the highest risk because intubation, extubation is what is dangerous. Those patients, those people need to follow the procedure of doing it in a negative pressure room and making sure for 15 minutes at least. That is probably the most common sense answer. And if the patient doesn't have symptoms suggestive of COVID, really nothing is a worry because the amount of virus is going to be so low in a subclinical infection. We are getting petrified about really nothing much. And when you look at the data that's coming from China about all the people who are elective and all that stuff, there's really been nothing happening.
Yeah, I agree. It's an enveloped virus, so it's liable to disinfectants.
Correct.
So we should not be worrying that much.
Absolutely.
Yeah.
Absolutely.
Another thing that you had mentioned was negative pressure rooms for taking samples. And again, negative pressure room in the operation theater. So I think it is easily said than done. Okay. I'm not sure how practical is it going to be to create a negative pressure room in an operation theater, leave alone for a sample collection. So we have to do a lot of compromises all along the way.
I'll tell you what we do. What we do is, when we do that, we can't do that in a negative pressure. We can't have a dedicated negative pressure room for this. That's not going to happen. So what we do is, we tell the anesthetist and whatnot to take the patient into the OT room, get everything ready. And when the anesthetist is getting ready to intubate, everybody else leaves the room and seals the door. If you have a door which locks well, that's the greatest thing that you can have. Then the anesthetist who's got a N95 mask and a shield, he goes ahead and intubates and then waits for 15 minutes and then the door is open and people go in. That's probably the best you can do. Unfortunately, having a dedicated negative pressure room is not going to happen. Nobody has luxuries like that. I agree.
Yeah, fine. Thank you. And again, thanks, Subra, and thanks, Dr. Ram Gopal, for moderating this session. And all our lectures have been really very good, practical. And looking at the comments that I get, I'm really very encouraged to conduct more such activities through the portal of SIDS. And tomorrow we have another lecture. The lecture topic would be lessons learned from other nations, the way forward for India. So that would be by Dr. George M. Verghese. People who missed the live action today can log into the YouTube and then type SIDS webinars to catch Dr. Subramaniam's lecture. And as usual, the lectures are uploaded in our SIDS website, sidsindia.org. Thanks a lot for joining on this auspicious day. This happens to be a new year for most of the states, especially for the South Indian state of Tamil Nadu and Kerala. Thanks for joining on this holiday day, and bye-bye. We'll see you again tomorrow with the last lecture of this current series. Thank you.
Live long and prosper.